For those of you I haven't met before, my name is Ryan Sharma, and I'm part of the CRS team here at CRISP. And I'm just going to give a quick introduction, and then we'll get right into the training. So just as a reminder, we're here today for training for the new CRS Total Cost of Care tool called Value-Based Care Insights. The acronym for that is VBCI, so you will see that everywhere. Quick background on it. In October of 2023, CRISP issued an RFP to enhance our suites of total cost of care monitoring tools. And the goal of the tool is to allow hospitals and the state to manage the costs of its Medicare population in comparison to relevant state and national benchmarks. The tool that we'll be reviewing was designed by Milliman Med Insight, who's here today with us for the training. The tool does use Maryland CCLF data, and I would like to also note that it uses a modified MPA attribution. So instead of attributing partials for beneficiaries, so like 40% to one hospital, 60% to another, 100% is attributed to each hospital, even if they're overlapping zips with another hospital. And I'm just going to quickly note that we do have two benchmarks in the reports. There's a Maryland benchmark and what's called a well-managed one, and the Milliman team will get into that during the training. Quick overview on how to access the tool because it is slightly different than the rest of our CRS reporting suite. Access to VBCI is directly through the CRISP HIE portal. And to get there, you navigate to portal.crisphealth.org. You log in using your email and password, and you will be required to do a two-factor authentication there. Once you're logged in, there'll be a tile that's called Value-Based Care Insights, and you'll click that. And just to note that you may need to click it twice right now. And then when you do log in for the first time, you'll also need to log into Milliman's system by selecting continue and accept, and there'll be two different screens. Just want to give you a heads up there. The VBCI tool will open in a new window as well. If you have any issues or questions around the tool, around access, please reach out to our VBCI support email, which is vbci-support@crisphealth.org. I'll also post that in the chat as well. And then as we're going through this, feel free to put any questions in the chat during training, or if you have any use cases that you'd like us to walk through, we're really happy and open to kind of using this time to best serve you as well. So once again, any questions, any use cases, please throw those in the chat. I guess this is our last training. Any questions, let us know. I think with that, I'm going to hand it off to Katie on the Milliman team to get started. And thank you all for joining.
You're muted, Katie.
Thank you so much. Thank you all for joining. Happy to have you all here on our last VBCI training for the CRISP group. Want to just start off with a couple of details on the data that we're using. As Raina alluded to, we are using the Maryland CCLF data. We do have 36 months, but we do filter that for 3-month lag. And we also have some caveats with the data that they are providing in that CCLF data. For example, they're not supplying us substance abuse or mental health claims. So when we're in the tool and you're looking at some of those service categories and you won't see any data, but that's simply because we're not getting that in the data itself. We're also using a demo site today because we do have folks joining us from all different organizations. So when I'm in the tool, you'll see some really wonky provider names, patient names, etc. It's your real data, but we're masking all of that so that you're not able to attribute specific patient or provider information. And then without further ado, I think I'll share my screen here and get into the tool. If you do have any questions at any point, please do feel free to drop those into the chat. I'm happy to answer those as we go along. I'm also just going to quickly stop sharing my video because it tends to have better performance when I am not on video. But what you're seeing on my screen right now is the welcome screen that you will get as soon as you log in via SSO. There are a couple filters that get created by default here. So it will tell you the time period that you're looking at. As a default, we're always going to look at the latest 12 months of data. So in this case, the data in the system is through April 30th, 2024. So we'd be looking at May 2023 to April 2024. There's a filter for assignment period. I'll talk a little bit more about this in a minute. But when we talk about CRISP assignment, we're looking at MPA attribution. And we look at assignment in two different ways. We look at whether or not a member is currently assigned to you. So for you all, a currently assigned member would be somebody who is attributed to your facility as of the current month. So in this case, April 30th, 2024. We also have assigned during current period, which would look at all of the members that would have been assigned to your facility at any given month during the current period that you're looking at. And then lastly, one of the driving status or filters that we have is beneficiary status. By here, we're always going to exclude ESRD by default. The reason being ESRD is handled a little bit differently, and we don't have benchmarks for our ESRD populations. So you're welcome to bring in ESRD if you want to look at that total experience. But one of the things that you'll notice as we go through the tool, if you were to bring in ESRD, you won't have benchmarks populated, and then you won't have opportunity dollars populated because those are also tied directly to the benchmarks. So those are three of our standard filters that you can select upon login. And when I click next, you're then going to be landed at our home page. So spend just a moment to kind of give you the navigation, the lay of the land of the portal before we start diving in. There are a few different ways to move around throughout the site. Here on the home screen, you're able to click on and navigate into any of these dashboards. So you could go to the executive summary, our cost model, or any of the additional dashboards listed. Those that are in gray just simply mean these are on our roadmap coming soon. So as the year progresses, you'll start to see these fill out. We also have a left-hand menu over here. So you can navigate back to any of these dashboards or any of the reports via the left-hand menu. And then lastly, we have our top menu. So what you'll find in the top menu is going to be a quick reminder of what is the data set we have in here. We can see we have our paid claims through April 2024. We have our global filters, which I'll jump into in a moment. And then we also have resources. Want to take a minute to call out resources because as we go through all of these reports, there's lots of different metrics. There's lots of different groupers and methodologies that we leverage throughout the tool. And in this documentation link, you'll find the data dictionary for VBCI. So you can get information on any of the metrics that we're talking about. In addition, you can get links to any of the methodologies that we're leveraging. So if you want more information on what the NYU preventable ED methodology is like, you can find that in the data dictionary as well. We also have a training video. So if you walk out of this and you're like, maybe you want a little bit more reminder or refresher on training, you can click that as well. So I'm going to go back into the global filters before we get set because you'll see here now we have a few more than we did on that intro page. So to give you the lay of the land of our global filters, we're going to start off with just kind of summary statistics so that you can compare the filtered population as you manipulate some of these global filters compared to the overall population. Any of these filters that you select, what we mean by global filters is that once you select them, as you navigate throughout the site, these filters will always be in place. You don't have to adjust them if you go from, report to report. They will always be there. So I talked a little bit when we logged in about time period. By default, we look at the latest 12 months of data, but you do have the ability to adjust that. You can adjust it in here or at that initial screen. You can look at a single month, 3 months, 6 months, etc. And then we also have a prior period. So by default, we're always going to have them in sync, where the current period is this year and the prior period is the year or the months previous. But you can manipulate this. So if you wanted to look at something like this year's flu season in comparison to last year's flu season, you can do that. If you want to look at the first 3 months of the year compared to the first 3 months of last year, you can do that. So you can kind of pick the current and prior. The reason why we bring in the prior is what you'll find as we go through these reports is there are a lot of trending metrics. And so whenever we have trends, what we are comparing is the data from the currently selected time period to the data in the prior selected time period. Then we have a few member level filters. All of your access is based on the facilities that you have access to. So if you are a member, you belong to a hospital system that has multiple facilities, like a John Hopkins. When you select the CCN, you will see all of the hospitals within your hospital system, and you can choose to look at one of them or look at an aggregate of them. And then similarly, we also allow you to slice or filter by zip code. If there's a zip code that you are more responsible for, that you want to zoom into a specific area of members. And then we come back to that currently assigned and assigned during selected period. So just as a reminder, if you were to select currently assigned, MPA attributed, you're going to be filtering the data to everybody who is MPA attributed to your facilities as of the latest month of data. So in this case, April 2024. If you select assigned during selected period, MPA attributed, that's going to give you everybody that was MPA attributed to your facilities as of the year months that are included in your time period. As I mentioned, we have the beneficiary status, aged, non-dual, disabled, age dual. By default, we don't select ESRD. If you do select that, you will lose the benchmarks and the opportunity costs. And then lastly, we have institutionalized. That's just going to identify whether or not a member is in a long-term care facility. All right. So that's number one. When you get in the site, make sure you're set and determine what your global filters are. And I'm going to go ahead and get started. I'm going to start with our executive summary. The executive summary dashboard is designed to give you that high level view to start to introduce you into the total cost of care opportunities that you have and your population. So what you'll see at the top are a number of KPIs, your total beneficiary years, the average normalized risk score, the per beneficiary per year dollars, the total paid dollars, and the total cost savings opportunity. We'll talk a little bit about benchmarks on the next slide, but we're always going to be calculating the total cost opportunity, excuse me, cost savings opportunity when we're comparing your actual performance relative to our well-managed benchmarks and what that equates to as a cost savings opportunity if you were to shift your performance to the well-managed level. You'll also note on each of these that trend period. And so that again is going to be the metrics that are comparing how you're doing now compared to how you were doing in the previous period that you selected up here in your global filters, which allows me to point out you will always have this breadcrumb trail of the filters that are selected. So if you ever are navigating through and forget what filters you have in play, you will always see that in the top right. As we move on, we have some summary statistics. So we have our overall beneficiary status summary. So we can look at our total average paid PBPY by each of our beneficiary statuses and their relative average risk score. And then we look at our top 5 cost savings opportunities. So this is a visual that's going to say of our service categories, which we'll see in our cost model next, what are the service categories that have the highest cost savings opportunity? What does that look like? And that's going to help navigate your journey kind of through value-based care insights to identify more details. I can see there's opportunity. Where is it? How do I obtain it? What are the details surrounding that particular opportunity? But here you'll get that first highlight, and then as you scroll down, you'll get some additional information on those top 5 cost savings opportunities. So we'll see our top 5. We have inpatient facility medical, we have outpatient infused injectable drugs, and then outpatient office visit specialist. You'll see what your average utilization per 1,000 is, the average paid PBPY, the percent of our total paid PBPY. The state of Maryland benchmarks paid PBPY, our well-managed benchmarks paid PBPY, and then our potential paid opportunity dollars, and then our potential paid opportunity percent. As I mentioned when we logged in, there are a few different ways to navigate. We have the left-hand menu, we have the home screen, but also within each of the dashboards, there's generally a link that's going to bring you into like the next level of detail from a dashboard. And so here you'll see if I want to know more about these particular service categories or additional service categories, I can click this link here to view all in our cost model. Similarly, I could come up to my left-hand menu and come to my cost model as well. I'm going to follow the dashboard story, and this is going to bring us into the cost model. This is kind of the bread and butter of the product. It's going to give you a lot of information across your experience in all of the various service categories and how how you're performing relative to our benchmarks. And then the subsequent reportlets that we'll start going into will be even further kind of deep dive in some of these specific categories. While this is loading, I'll just take a minute now to tell you about how we calculate the benchmarks. We have two different benchmarks. We have the state of Maryland benchmarks and our well-managed benchmarks. Both of these are empirical benchmarks that are derived from the Medicare 100% Innovative Research Database, which includes all of the Medicare Part A, B, D paid claims for Medicare fee-for-service beneficiaries. So it's a super comprehensive data set that allows us to get really precise insights into Medicare utilization. For the well-managed benchmarks, we use an empirically based methodology to consider the risk adjustment utilization patterns for various hospital referral regions and the interaction of those within service categories. The well-managed is the top 10 percentile of the highest efficiency HHRs, hospital referral regions. And then all of the benchmarks are risk adjusted to reflect the specific mix of your population, considering your Medicare eligibility status and your HCC risk score. So that's for the utilization benchmark. Then we have the cost benchmarks. So for the cost benchmarks, we're actually calculating those by applying your specific population's average cost per unit to the utilization of our well-managed utilization benchmarks. So this is going to ensure that when you're looking at the opportunity or the cost benchmarks that we have, that they are reflective and tailored to CRISP's current cost of care. The state of Maryland benchmarks then, same data set, same data source, and then we're just filtering that down to all of the Medicare beneficiaries out of the state of Maryland. All right, so now this is loaded. Want to take a minute to kind of give the navigation here. We are breaking down everything by service category. We use the Milliman Health Cost Guidelines to categorize all of your claims data into these various service categories. From a functionality perspective, you're able to kind of group these up, and you can see that at the highest level, we're going to look at your inpatient service categories, your outpatient service categories, and then a slew of other ancillary services. So if you want to just be looking at something specific, you can always use these arrows to group, roll up, or expand. So I'll use our inpatient facility as an example cost summary to start walking through. You can see here we break that out into both medical and surgical inpatient facility admissions. And so the things that we're going to look at and the common theme that you're going to see across most of these dashboards here are going to look at utilization. So what type of utilization are we looking at when we say utils per thousand? So of course, right now we're looking at admits. What are the actual admit per thousands from your experience? What are the admits per thousand for the state of Maryland benchmarks? What are the average utils per thousand for our well-managed benchmarks? And how are you trending over your time periods, current to prior period? Then we look at similar items, but from a paid PBPY perspective. So we're going to look at our average cost per service, our percent of paid PBPY, the total paid PBPY, and then how that compares to the state of Maryland benchmark, as well as the well-managed benchmark. And then we have the opportunity. So when I alluded to on the executive summary, the opportunity for reduction in paid PBPY is really going to be comparing your total actual paid PBPY to the well-managed benchmark. And then we take your unit cost and calculate out what that is in a dollar perspective. And then we can also look at the opportunity for reduction in paid PBPY as a percent of your total paid. Okay. So this is a great next spot to, oh, I think there was a question here. Let me check the chat. For the trend period versus prior, is there any way to see how the state of Maryland has trended versus prior? Not currently. It is just going to be for your actual performance, but that is a great question and something to consider. All right, so this is the cost model summary. It's going to start to give you that insight on how you are performing and across all of these different service opportunities. And from there, we can start drilling in. So if we were looking at our inpatient facility medical admissions, and we know that we've got, a 3.5% opportunity for reduction in our PBPY, and we want to know more about that. Is this designed then to go ahead and drill into that next level? So anywhere that you see a hyperlink, you can click and drill into. Again, you could always access this directly to in the left-hand menu. So I'm going to click into my inpatient medical dashboard. And now this is going to just give me some additional context into that opportunity. Give this a minute to load. As this is loading, what you'll find the layout across each of these different service categories that we have. So we'll do deep dives into our inpatient medical, surgical, skilled nursing, ED, urgent care, home health, etc. The layout is relatively the same. The very first block that you're going to get is going to be the key summary. These are the same exact statistics that we just got from our cost model. So that's going to show you as a reminder, here's your overall performance and why you're drilling into this particular dashboard. And then as we roll in, we'll get more and more specific information. So first thing that we can see is how have our inpatient medical admits been trending over time. You can look at this by a monthly, quarterly, or yearly basis. And all throughout the tool, you'll also notice that all of the reportlets have a download button. So if this is something that you want to download and attach to a PowerPoint that you're doing or download to do research, download to Excel, you can access that through each of the reports. In-network utilization, you'll see, is not populated for CRISP. We don't have any sort of provider roster or network utilization currently. That may change in the future, but if you are wondering why that is 100%, it's just a field that we're not quite leveraging yet. And the first place that we want to start when we're investigating our inpatient medical admissions is really at the DRG level. So we have our first breakdown at the DRG family level, or you can see there's a toggle here with a tab. If you want to go to a specific DRG, you certainly can. And we're going to get a little bit more insight onto those particular admissions. By default, this report is sorting by total admits, but you can click and sort on any of the metrics, and this functionality exists across all the tables. If you want to look at, highest average length of stay as an example, you could certainly kind of rearrange the tables that way. So now we're just starting to get a little bit more detail on these particular inpatient medical admissions. I'm going to focus on heart failure. So heart failure has a total of 6,817 admissions. That's a rate of 9.9 admits per thousand. The average length of stay for our heart failure admits is 5.5. Of those, 6.4% were one-day stays, so maybe some opportunity there. The 30-day readmission rate, 20.1%. We can see what our total pay or our paid PBPY is for those admissions, our average paid per admit, and then the percent of our total paid PBPY that these heart failure admissions are costing. I'm going to keep scrolling over here. I will call out that as of right now, we don't have DRG level benchmarks for the state of Maryland, but that will be coming soon. And then as we move over here, you'll get that DRG family level benchmark for our well-managed. So the well-managed average admits per thousand is 8.4, and the average length of stay for our well-managed heart failure admits is 4.5. And then again, we're always going to look at the opportunity. So what is the dollar opportunity for reduction in paid PBPY? And then what is the opportunity for reduction in the paid PBPY as a percent of our paid PBPY? So we know we have some opportunity in heart failure. I've selected that as a filter. This is another piece of functionality that you'll see across the platform. As soon as you select a filter, all of the reportlets below will have that filter on them. So if I look above, it's still the higher level summary, but everything below, as I scroll down, you'll see have the three selections because I selected the DRG family of heart failures, and here are the 3 DRGs that are included in that. So now that we know here's some opportunity in this DRG family, I want to know a little bit more information. It's going to go to the facility level information. So again, this is all blinded information, which is why the facility names and CCNs are nonsense. But what this is going to do is show you the facilities that have had these admissions and some additional metrics about that. So we could look at this first facility here, select that. They had 574 heart failure admits. That was 8.4% of their total medical admits. You can see the percent of admits of these that came through the emergency department, how many were one-day stays, what that 30-day readmit rate is, what that paid PBPY is, and again, what that percent of paid PBPY is. We start at the facility level. There's another tab here at the actual individual provider level. So if you wanted to get more specific than facility, you could toggle there. I did select this top facility just to show you now there are 2 filters selected. So now I'm going to come down to the next level of detail. We know the DRG family we're looking at, heart failure. Focusing in on facility A that had some opportunity. Now I'm looking at the beneficiaries that are making up these heart failure admits at this particular facility. What I want to call out on this piece is that we are following CRISP's PHI rules. And so in order to actually get beneficiary details here, your facility must have had a touch with that patient or have that care coordination agreement in place. So there may be instances where you have less members here than you're expecting. You're expecting that 574. And the reason for that would be that one of those 2 pieces is missing. You didn't have a touch, you don't have a care coordination agreement, and thus we're not surfacing that member level information for you. But here, next opportunity to dig in and see what additional, interventions maybe could be done at a beneficiary level. We'll give you some specific information for that member, what their name is, how old they are, who their attributed PCP is using Milliman's PCP attribution methodologies, what that average risk score is, whether or not it was a 30-day readmit, what that admit date is, discharge date, and whether or not that came through the ED. And again, here you could download that if you wanted to take this patient panel and start working through any sort of outreach, etc. So that brings us through the first, which is our inpatient medical dashboard. We follow the same sort of layout kind of throughout each of these deep dives. So for the purposes of this training, I'm going to skip over a couple. But if you wanted to look at inpatient surgical, it follows very much the same storyline. I'm going to switch over to the emergency department because I think that's always a fun one and a great one to focus on. As this loads up, as a reminder, this first tile that we're going to see at the top is going to be our overall utilization compared to benchmarks. This is going to come right out of the cost model as well. So if we were back in our cost model dashboard and we were at the emergency department, it's going to be the same measures here. You could click and follow through to this reportlet as well. But we're going to break up our emergency department and then our urgent care to look at our overall performance. So same layout, same look and feel. You're going to get your actual performance, what your utilization per thousand is compared to the Maryland and well-managed benchmarks. You'll be able to see your trending over time, and then you'll be able to see what the financials look like. What is your average cost per service? What is the percent of PBPY? What is the total paid PBPY? And then how does that compare to our Maryland and well-managed benchmarks? In those instances where our performance is above well managed, what then is the opportunity for reduction in our paid PBPY if we were to drive our performance down to the well managed level, and what percent of opportunity for reduction is that? We start to slice EDs a little bit different as well. We start to bring in another methodology, the NYU algorithm for preventable ED visits. Again, if you're not super familiar with that particular methodology, you can find it up in the documentation in the data dictionary. There is a link that can explain that methodology in a whole. But in a nutshell, it's going to look at all of our emergency department visits and determine the probability on whether or not that was a preventable visit or not. So we'll start off with some key metrics. What are our total ED visits? What percent of ED visits were preventable according to the NYU algorithm? What is the total paid preventable ED visits? And then the paid PBPY for preventable ED visits. As we keep scrolling down, very similar, you'll be able to trend that ED performance by year, month, quarter, or year. And then we'll start to get into some of the more deep dives on these ED visits. So we start out at the hospital level, where we can look at the emergency department visits by facility. What were their total ED visits? What were the total preventable ED visits? What's the paid PBPY for those preventable ED visits? What's the paid PBPY preventable ED visits as a percent of your total ED paid PBPY? And then what percent of ED visits overall are preventable. And then we start to look into more of the classification from the NYU algorithm. So for those that were preventable, the NYU algorithm will categorize those as emergent preventable, emergent PC treatable, or just non-emergent visits. So you can see how a facility is doing across those metrics. And then for those non-preventable ED visits, were those emergent necessary, injury, or other? Okay. So we have a hospital breakdown. We also, again, could do it by the provider up here on the tab, or even by diagnoses. If you found a facility of interest that you want to dive into, I can select that facility. You can see the facility filters here. As I continue to scroll down in the dashboard, I'm going to come to that patient level detail. So this is going to give me the patient panel for all of those ED visits at this particular facility, and then the relative or the relevant metrics around that. So give me that member information. How old are they? What is their normalized risk score? Who is their assigned PCP provider? How many total ED visits has that patient had? How many of those ED visits were preventable? What percentage of ED visits were preventable? What was the total paid in these ED preventable visits? And then how many urgent care visits does that member have? And then similarly, it's going to break down those member visits by the NYU algorithm classifications. So for those preventable ones, how many were preventable, emergent preventable, emergent PCP treatable, non-emergent, and then those that were not preventable, how many were emergent necessary due to an injury or other. All right, I think I'll do one more of these just to show you a home health. And I asked you to go in there if you are navigating, skilled nursing and have questions, or DME supplies and have questions, feel free to reach out to the CRISP support email address. We'll make sure to answer those as quickly as they come in. Switching over to home health, again, look and feel is going to be the same. These are overall home health statistics, how your actual performance is, and then how that compares to the state of Maryland, as well as our well-managed benchmarks, what your trending looks over time, and then what those cost savings opportunities are. We can do the same trending by month, quarter, or year. And then we can start to dig into the home health agency detail. So this level is going to give the actual home health agencies and a summary of their performance. How many total home health cases did they have? What percent of home health cases belong to that particular agency? The number of unique patients receiving home health, the total paid PBPY for home health cases, how many of these, what percentage of these were initiated within 3 days post-hospital discharge, the percent initiated within 3 days of a SNF discharge, the percent initiated within 3 days of an inpatient rehab, and then the percent initiated within the community. Again, same concept. If you want to pick a specific home health agency, dive into the patient panel. Specific to that, we can, we've got one more before that. We can come into a few different readmission metrics for that specific facility or other facilities. So we've got our total cases, and then we're going to break it out between cases within 3 days of a hospital discharge, cases within 3 days of a SNF or IRF, and then cases within 3 days of an inpatient SNF, IRF, and then what that performance looks across the board. Okay. And then we can get down to the providers. So who are the assigned PCP providers for these members that are having these particular home health cases? And again, looking at those same 3-day metrics across that provider. And then lastly, the beneficiary panel. So right now you can see here, I have only selected one home health agency. And then I can see all of the different home health cases for these members at that agency. So in this example, this member has a few home health visits, and you'll be able to see the associated details there. When is the first home health claim, last home health claim, cases within 3 days discharge, cases within 3 days discharge from your SNF or an IRF. All right, awesome. I'm going to keep moving along here and look at our post-acute care dashboard. So this is a little bit different. This is the first time we're introducing a new dashboard, not tied directly to our cost model. But what our post-acute care dashboard does, and what we're looking at here, is that we're going to take and create 30-day post-acute care episodes. And then we're going to look at the resource utilization in different care settings within that 30 days following that hospital inpatient discharge. So some of the key metrics we're going to look at is the post-acute care paid as a percent of your total PBPY, and what that cost savings is as a percent of your total PBPY. We do have well-managed benchmarks for our post-acute care. These benchmarks are different than the well-managed that we use in the cost model, but developed very similarly. So they're still using that 100% Medicare research database, and we're creating these benchmarks by DRG. And we're going to create these benchmarks for all of the DRGs that we see in those post-acute care episodes that have sufficient and credible data. So we won't have benchmarks for every DRG, but for anyone that has enough data to be deemed credible, we certainly do. And we're going to look at our opportunity in a very similar way as we have across the cost model. So here you can see at a high level what the contribution to total PBPY is for these PAC episodes, and those that had skilled nursing had resource utilization in skilled nursing facilities, inpatient readmissions, home health, and acute inpatient rehab. Our PAC cost savings opportunity by service. So if we were to move this resource utilization to be closer and more aligned to our well-managed benchmark, what does that cost savings opportunity look like if we moved to well-managed SNF, inpatient readmissions, home health, and acute inpatient rehab? As we scroll down, we start getting into more details. For each of these PAC categories, we can look at what the total paid PBPY is, what that PAC paid PBPY is as a total, percent of total, what that trending is from current period compared to prior, and then the percent of PAC episodes with utilization, what your actual resource experience was compared to the benchmarks. Similarly, we look at average days per PAC episode. So how many days for SNF, for example, your population had for actuals compared to our well-managed benchmark. Then we look at the financial side. What is the average paid per PAC episode? What is the benchmark paid per PAC episode? What is a cost savings opportunity per PAC episode? And what is the cost savings opportunity paid PBPY, and then the cost savings opportunity as a percent of your total paid PBPY. From there, we can start to go, start digging, excuse me, a little bit deeper and look at the hospitals. So these are going to be the hospitals that had that inpatient discharge and start to look at their measures. So we can look at how many PAC episodes do we have as a result of an inpatient discharge at this facility? What percent of total PAC episodes that makes up? What the PAC paid PBPY is? The PAC paid as a percent of total, et cetera. And then we start to look at that particular facility's discharges and which utilization resources were used post-discharge compared to benchmark. So how many went, how many had a readmit compared to benchmark, how many of those PAC episodes leveraged inpatient rehab, what percent of those had SNF resources, and what percent of those had home health visits. As we scroll down, we can take it the next step further. You can see I still have my hospital A selected here, and now I can start to drill into those particular hospital stays and what the DRGs were for these episodes. Similar to our inpatient cost model dashboard, you can look at DRG family, or if you'd rather, you can look specifically at individual DRGs. And we're going to look at the same exact measures that we did right above, but then specific to heart failure admissions and what does that PAC episode experience look like for those particular members. All right. Briefly touch on our end of life measures. So if you're interested in the spend in that end of life period, we do have a number of different metrics that you can leverage here. We can look at what your annual mortality rate is, how many deaths you had, what the average paid was in the last 3 months of life, what that total paid in the last 3 months of life is as a contribution to the total paid PBPY. And then we can look at some risk adjustment rates measures. So how many of these deaths occurred in a hospital? How many were in the ICU 30 days prior to death? How many were in acute IP hospital? How many hospital days in the last 6 months of lives, et cetera. And then as you scroll down, you can get to the beneficiary details and look at those individual members who've passed away, what their utilization was, what their average length of stay was, how many hospice days did they have, were they in the ICU, et cetera. All right, and then we want to make sure we have some time to talk about our chronic condition detail, another great dashboard here. As this loads, we use the Milliman chronic condition hierarchical grouper to categorize all of the claims experienced into chronic conditions for our members. And so this board is designed to kind of give you insight on your population, what chronic conditions they have, and then what contribution to spend do these particular conditions have. At the highest level, we're going to look at all of the various chronic conditions from the CCHG grouper. Again, just a plug if you're interested in the methodology that Milliman uses for our HCCs, or excuse me, for our CCHGs, that can also be found up in the documentation link in resources. But we can look at how many total beneficiary years have a particular chronic condition, what that prevalence rate is, what the normalized risk score is for the population that has this chronic condition, what the average paid PBPY is for beneficiaries with that condition, and what that contribution to the population spend is. If I wanted to drill into diabetes as an example, you can see now as a filter, I'm going to look at the prevalence of diabetes and everything else. So now this particular report shifted a little bit. It's going to look at the members that have diabetes and any of these other conditions. So we can see this member, 100% of them have diabetes. And of those people who have diabetes, there are another, 160,000 of those members also have hypertension as a comorbidity. And you can start to look at the comorbidities across and prevalence across that population. As I scroll down, then you'll get the additional list of members, that beneficiary panel for people with those selected conditions. So right now I'm just looking at the beneficiaries that are attributed to me that have diabetes. Who are these members? How old are they? Who is their PCP, attributed PCP provider? What is their normalized risk score? What is their paid PBPY? What are the other chronic conditions that they have, and how many chronic conditions do they have? So we'll list out, and you can kind of hover over to get the kind of list of each of the different chronic conditions that this particular member has. So those are the 5 chronic conditions that they have. And again, you're able to export this. So if you did want to kind of have a list to work with and slice and dice any way that you want, you could certainly do so. There's a question that came in that says, are years counted multiple times if a beneficiary has multiple conditions?
I
Go ahead,
think,
Michelle.
I think so. I think people are in multiple categories. Unless is the number of many years matching?
This is, yeah. So I'm filtered for diabetes. We know that we have 183,000 Benny years total. So that's our total.
Oh,
but
yeah.
then these are the duplicates. So these are, of the 183,890, there are also 163 of those folks that have this chronic condition. So to answer your question, yes, they will be counted individually if they have comorbidities. When you have no filter, then that should just be the straight. No, I take that back. They are counted multiple times if they have multiple conditions. Great question. All right, that brings us through the bulk of the dashboards here. I want to open it up and make sure that we have some time for more questions. Thank you so much for those who have dropped them in the chat already. Does anybody else have any questions or anything you'd like me to circle back on? Abigail?
I thought this would be easier to say. So this requires the end user to do a lot of drilling to find the end goal. kind of thing, or like the area of most impact. Do you see in the future with AI or different things like that, that you'll be able to just pull that up for the end user? Does that make so like with this, I have to go into inpatient medical and then and see what are the drivers in that? What's the drivers in skilled nursing? And do the drill down in each little category. Do you see is a next step to make the tool less drill down intensive or not? Or this is the end goal, end product?
I think that's a great question. And a great thought. I think the idea is to give the story and help kind of lay the land of where the opportunity is, but give enough information for a user to kind of navigate through. But I understand that feedback of, hey, why don't you just serve it up what you think is the best instead of kind of walking through that storyline. I am not sure off the top of my head if the product team is looking at going that way, but that's certainly feedback that I'm happy to bring to the team. Michelle, unless you have anything to add to that.
No, I don't. I think that, well, I'll just say, I think that we're wanting to present the data, right? Like there's so much data that we're processing and behind all of this, and we are trying to develop like prescribed reports that are summarized but still give the user's ability to dig in and look at data without having to process administrative claims data yourself. So I think there's a balance, I think, within the tool where we're trying to identify opportunities and give you some high level stats, but also allow the user to dig in further and to understand the data, because there's certainly different levels of users, right? And we want to be able to serve those different user types as well. But I mean, I think your thought or your question is a good one. It's not something that I've been involved in discussions with, but certainly something we could think about.
Hi, this is William Henderson from the HSCRC. A couple of thoughts here. One, I do think if you go back to the cost model and the opportunity, right, that is meant to be the first step in what Abigail's describing, right? Where basically, okay, which of these areas should I focus on? Let's look at the opportunity, and I'll focus on the one that has the biggest opportunity. So I do think that's sort of trying to get somewhat to that idea of giving you some initial guidance, right?
Yeah, that's right.
But I would also agree with Michelle that, we're always sort of trying to thread the needle between providing something to somebody who kind of just wants the answer, but then we have a whole bunch of users who are like, no, don't do that because, I've got a bunch of my own programs and I want to understand how they're doing. And if you just, immediately lead me to the things you're important, then you haven't helped me because I might think of different things are important or want to look at it different ways. So we are really trying to balance giving you some path to go down, right? And I think we would recommend, if you want to know what path to go down, you go to this thing and you say, where's my biggest opportunity? And that's the one you spend your time on. But at the same time, we're also trying to support users who maybe are, have a different use case and a different approach. And, this says, okay, biggest opportunity is inpatient medical, but I might think, I don't know, I know all about inpatient medical. We've got 18 initiatives there. I don't care about that. But I'm interested that we've got a large opportunity here in SNF I haven't thought about, so I want to drill down that. So I do think there's sort of a compromise that you're trying to balance there between drilling in on very specific things and giving people a more general tool that they can use to explore their own issues.
Absolutely.
Thank you. That makes a lot of sense. Oh, and the other idea was this is all if there is another way to duplicate this cost model, but like pivot it on your major diseases as opposed to the major services. So like diabetes patients, like look at it that way. But no.
Yeah, And that is
appreciate
on
all that's
our,
here.
yeah, that's a great point. That is on our roadmap to kind of provide some key metrics on certain chronic condition cohorts. So maybe not as detailed cost model, because we won't, at least in the short term, have benchmarks at that level of granularity, right, by these condition cohorts. But we're certainly thinking through, like, what are the KPIs, what are the metrics and utilization and such that we'd want to show by chronic condition cohort. So yeah, that is on our roadmap.
Yeah, I would agree. I mean, having filters on those would be interesting, right? Because you can filter this to a specific set of zip codes, for example. But yeah, being able to zip code filter and look at the care delivered to people who meet diabetic chronic conditions, it'd be an interesting approach.
Absolutely. Great questions, great feedback. Anybody else have anything? We've got 3 minutes left. Well, I thank you for taking the time to join us. Please do jump in the tool. If you run into any questions once you're in there, feel free to shoot those over to the support inbox, and then we'll get you those answers. Thank you, everybody. Have a great day.
Yeah, thank you, everyone. Take care and thanks for joining.
Thanks all.